Welcome back, focused learners. I am beyond excited for today's session because, well, we are tackling an absolute heavyweight of medical exams. We're diving into a rapid-fire, high-yield explainer specifically designed to help you absolutely crush Neisseria meningitis questions on your board exams. We're taking the most essential, heavily tested material and breaking it all down right here, so you can lock in those points on test day. Let's get into it.
Here's your high-yield blueprint for conquering meningococcal disease logically and efficiently today. Pathogen traits and basics, epidemiology and risk, clinical features, meningitis versus septicemia, emergency protocols, and finally, prophylaxis and vaccines.
Section 1. Pathogen traits and basics. Know your microbes.
Okay, so here's a classic board examiner trick. They absolutely love to test if you can differentiate between the two major Neisseria species. So how do you do it? You look at the sugars. Neisseria meningitis utilizes both glucose and maltose, whereas Neisseria gonorrhea, that one only uses glucose. Identifying that maltose utilization is literally the key to locking in the correct diagnosis when you're staring down a tricky microbiology vignette. Just remember, M is for meningitis and M is for maltose.
Let's rapid fire through some must-know foundational facts. This bug is a gram-negative aerobic diplococcus. It's both oxidase and catalase positive. Crucially, humans are its only reservoir, meaning you are definitely not going to catch this from an animal. Its virulence comes from an antiphagocytic polysaccharide capsule, plus an LPS endotoxin that triggers just a massive inflammatory cascade. But you know what's really wild? The kicker here is that asymptomatic nasopharyngeal carriage is actually the most common form of this bacteria. Up to 25% of young adults are just walking around with it in their nose and throat without any symptoms whatsoever.
Section 2. Epidemiology and risk factors. Who is vulnerable?
Look at this massive number, 600. The crucial takeaway here is that patients with a terminal complement deficiency, specifically C5 through C9, Properdan, or Factor D, have a 600-fold increased risk of developing this disease. That's huge. You'll also see this massive risk spike in patients being treated with the drug eculizumab. If a clinical vignette mentions a patient with a complement deficiency or recurrent Neisseria infections, alarm bells should be ringing in your head immediately.
Now, this disease has a really distinct bimodal age distribution. Your first peak incidence hits right in infancy, specifically in that very first year of life. The second peak strikes during adolescence and young adulthood, usually between 15 and 25 years old. And as a quick, high-yield bonus fact to tuck away, tobacco smoking heavily increases your risk too, bringing an odds ratio of 4.1 for meningococcal disease.
Section 3. Clinical features and red flags. Spotting the danger.
Let's walk through the terrifying speed of this rash progression. It often starts off innocently enough as a blanching rash with some macules or papules, but it rapidly turns non-blanching and petechial. Then it expands into a purpuric rash, and finally, in the really severe cases, it becomes purpura fulminans, presenting with large purpuric lesions and peripheral ischemia. Now, keep in mind, while over 80% of cases do develop a rash, the sheer absence of one does not rule out the disease. Some patients, even in overwhelming sepsis, have absolutely no rash at all.
Listen up, because here is a critical examiner trick for you. Hypotension is a late sign in children. When you're looking at a pediatric case, do not wait for the blood pressure to drop to diagnose shock. Children will compensate with tachycardia and poor peripheral perfusion first. Basically, if you're waiting around for hypotension, you are waiting way too long.
Section 4. Meningitis versus septicemia. The core clinical showdown.
Let's break down this comparison. We've got meningococcal meningitis on one side and meningococcemia, or septicemia, on the other. Meningitis presents with your classic triad: fever, neck stiffness, and photophobia. The exact mechanism of death here? Raised intracranial pressure. Septicemia, however, is the most severe and rapidly fatal form. It starts off flu-like, but rapidly devolves into hypovolemic shock due to intense capillary leak and endothelial injury. That hypovolemic shock is the actual cause of death. You absolutely must firmly separate these two mechanisms in your mind for exam day.
And because of that exact difference in the mechanism of death, I need you to literally burn this warning into your brain. A lumbar puncture should be absolutely avoided in meningococcal septicemia. Why? Well, simply positioning a patient for an LP will critically compromise their circulation when they're already facing life-threatening hypovolemic shock. You can delay the LP. Do not kill the patient trying to get a tap.
Section 5. Emergency treatment protocols. Saving the patient.
The crucial point here is your empiric treatment. You've got to hit them fast and hard with a third-generation cephalosporin, like ceftriaxone or cefotaxime, and you'll often add vancomycin empirically just to be safe. For the shock, you need aggressive fluid resuscitation and inotropes. And hey, please reassure your attending that starting these life-saving antibiotics is not going to ruin your diagnostic yield. PCR actually remains positive for days after antibiotics are started, which increases the diagnostic yield by over 40%.
Section 6. Prophylaxis and Vaccines. Prevention is key.
Okay, let's look at how test writers love to distract you here. For close contacts, who, by the way, have a massive 1,000 times background risk rate, prophylaxis is an absolute requirement. Test writers love throwing rifampicin into the multiple choice options just because it was used historically. But look at the data. It only has an 80 to 85% efficacy rate, and it requires 4 whole doses. The actual best choice? That's ceftriaxone. A single dose gives a 97% eradication rate, and it's totally safe in pregnancy. Ciprofloxacin is also highly effective as a single dose, but you absolutely must avoid it in pregnancy.
Oh, and here is a super sneaky little fact for you. Let's say your index case was treated with penicillin, which is totally appropriate once susceptibility is confirmed. Penicillin will absolutely cure the invasive disease, but it does not reliably clear the nasopharyngeal colonization. What does that mean for you? It means you still must give a prophylactic agent at the very end of their treatment just to eradicate the carriage.
Now let's contrast the immunology behind our vaccines. Polysaccharide vaccines are T-cell independent. That means no memory B cells, short-lived immunity, and honestly, they just don't work in infants under 18 to 24 months because of immature marginal zone B cells. But conjugate vaccines, where the polysaccharide is linked to a carrier protein, like a tetanus or diphtheria toxoid, those are T-cell dependent. They create memory B cells, they give a solid booster effect, and they actually work to protect our most vulnerable infants.
This actually leads us to one of the absolute coolest biological exceptions in all of medicine. For serogroup B, no polysaccharide vaccine is even possible. Why is that? Because the serogroup B capsule is structurally identical to a self-antigen found naturally on fetal neural cells. If we used it, the body just wouldn't mount an immune response. So science had to get really clever. To protect against serogroup B, we use vaccines made of recombinant proteins combined with outer membrane vesicles. It's a perfect bridge between immunology and microbiology, and it is a classic high-yield board question.
Wow, we've covered a tremendous amount of ground today. Let's end with a provocative thought to tie it all together. Ready? If a 19-year-old with a complement deficiency presents with a blanching rash that rapidly turns petechial, what is your immediate next step and what procedure must you strictly avoid? Think about it for a second. Got it? The answer is, hit them with a third-generation cephalosporin like ceftriaxone immediately and strictly avoid a lumbar puncture so you don't send them into fatal hypovolemic shock. Keep reviewing these insights, stay focused, and you are going to absolutely crush this topic. Thanks for learning with me today on The Explainer. Catch you next time.